To
Doktor Patrick Treacy'nin ikinci sunumuyla devam ediyoruz. Dolgu maddelerine bağlı körlük, güncel bilgiler, risk faktörleri ve yönetim stratejileri başlıklı konuşmasını yapacak.
So this is the history of dermal filler blindness. And of course, hyaluronidase comes into that in a big way as well. I intimated earlier that we were having problems with blindness for the last, probably now, 70 years, when they started injecting fat into eyes as tear troughs. Embolization, I think the first one was 1952, which is quite a long time ago. So that's me, and that's me. So the first thing is, before we get too worried, dermal filler blindness is quite rare. Now, I and some of my colleagues head up a world, I suppose, group on this, the ISAC group, in terms of dermal filler blindness. So I'll sort of run through it. So as I said, blindness happened after fat injections a long time ago. There's a paper there that was published in 1982, but it shows evidence back to the 1950s of it happening. Why does it happen? It happens like this. So you know that there's an anastomosis that's created between the internal carotid circulation and the external carotid circulation. And this diagram shows that something injected near the supratrochlear or supraorbital can retrograde, make its way back to the ophthalmic artery and then into the central retinal artery. Now, this can happen 2 or 3 different ways. So the first one, if you look at A, that is one of the cutaneous branches, obviously in this case the supraorbital. So if you inject the supraorbital, you run a risk of causing blindness. The second one, B, is down here, and that's a remote site. So that can be, for instance, your nasolabial, your alar artery, and there's an anastomosis between the angular artery back up here, through, and as a consequence, you can go blind. Then C is you can have an AV shunt in the glabella region, and D is obviously in the orbit between the ophthalmic artery and the vein. I had a case of blindness shown to me 3 days ago from the United States, and we think that it may be venous. You don't see it very often. Well, actually, the patient didn't go blind in the end. They restored their sight, but they lost the function of their eyeball, and that was the external ocular muscles were affected. So it's quite rare that it would affect that, and the ciliary branch missed the retina, so it could be venous. So this is cases around the world where we see where they are, and Britain, Turkey has had some cases of blindness. It's had 2. Most of them are in Asia, China, Korea, Vietnam, and we have them. The United States has had 13 cases of blindness. So it's interesting. This is where you can get them from. So this is important as well. The nose is the most common by far. The forehead, then, if you're going to inject the forehead, the no-fly zone is in the middle. You know that. Superficial temporal comes up halfway, you know that. So if you're going to go in, just go in with a cannula above the eyebrow and go across. And if you're going to do the forehead from the top, do it down, no-fly zone in this area. Then the glabella, the temple, like is here. So again, this shows the possibility of visual complication as a result of where you're injecting. So there may be a slight overlap here. So when hyaluronic acid came on board, we said, wonderful, we can reverse it. And if we can reverse it, we probably can reverse blindness. So I've gone into this before on sort of my different methods, but I had said to use the supraorbital block. We do that every day if we're doing lasers. At the supraorbital notch, and 1 mil of lignocaine with adrenaline. I tend to use In Ireland we can get this. I think in the United States you can as well. It's Zalkian with adrenaline. And normally 1 mil here will cause paresthesia of the whole central to almost the area above the eyebrow, right up to the... So this is a very easy block to do. You feel the supraorbital foramen, and as a consequence, anybody who does laser resurfacing here on their regional block, you do it. Turkey is well known for doing hair transplants. You can do that also to sort of anesthetize part of the scalp. So this patient here was the first vascular occlusion that allowed her pictures to be used on the internet. She's a nurse from California, and her name is Julie Bass. She lost her house during the Californian fires, unfortunately, and this is the way she was. This is her and her husband in London, in Dublin, sorry, when they came to visit me. Her husband's a plastic surgeon. So as a consequence, we had looked through that. This was the first case. There's a slight overlap here. So let's get up. So in 2012, when we started noticing there was a lot of blindness, particularly in Asia, Jean Carruthers, who had contributed to bringing Botox into aesthetic medicine. Jean is a friend of mine, a very important doctor in terms of the history of aesthetic medicine. Maybe the reason that most of you are in the room. And Jean had advocated the retroorbital method. Now, Jean's a vascular surgeon for ophthalmology, so obviously they do that all the time for doing cataracts. I thought at the time, it'll not work, there's no connection. So at the time, I sort of had raised my suspicions, and this is the way I suppose that it's done.
To make sure that we're not in a vessel, and now advance the plunger, delivering just about 3, maybe 4 cc's of anesthetic in the retroorbital space, in the conal space. And you can see the globe coming forwards there when we deliver the anesthetic. Now just a little bit of pressure there on the injection site. And let's review. These 2 green X's are the approximate placement for retrobulbar injection. Inferolateral. So away from the rectus muscles, away from the inferior oblique muscle, this is the safest spot to go. And you should stand on the same side as the patient when you do the injection. Now our goal is to get in that retrobulbar intraconal space. So when you pass the injection, the 2 pops you'll feel with...
The problem with doing the retrobulbar is, of course, that you have to be trained to do it, number one. And the second thing is you can damage the eyeball. Now, if you have a doctor who's a GP and somebody gets a heart attack and VFib, you don't send them to a cardiologist, cardiac surgeon, you treat them yourself. Why? Because they're going to die, they've got a heart attack. So everybody learns to do CPR or to give drugs, verapamil, adrenaline, and it's the same thing with your eye. It's worse. You could survive a bad heart attack for maybe 2 or 3 days. I know we stent them now so people don't die like they used to, but we're not stenting eyes, and you probably have 30 minutes, the golden zone, so you don't send them to the hospital and you don't send them to an ophthalmic surgeon. I'm not saying you shouldn't. I'm saying in the beginning, you've got to treat them yourself. They're going to lose their eyesight. So you want something simple and you want something you can do, and then the hospital can follow through. So at the time I had said that if you inject this way, there's dura mater surrounding the optic nerve and the central retinal artery and the ophthalmic artery. So the hyaluronidase will not reach there. I had sort of published a lot of things, and even then, back in 2015, I said I have reservations about the retroorbital method, and I've expressed my opinion in many articles. My reason for suggesting it is risks are high, vision rescue is very unlikely, and the central retinal artery with the nerve where the embolus is lodged is covered by 3 layers of meninges. I had sort of advocated that this should be used, and I had sort of had pushed that. Even in Paris, I said we shouldn't do this because new injectors, don't know how to do it. And what happened was the years passed. So in 10 years, up until 2022, we hadn't one case that it worked on. The Asians, particularly the Chinese, started complaining and saying, why are we doing this? I mean, there's no evidence it works. There was one case by Chestnut that maybe it worked, if you look up the literature, but the thing was he'd done the supraorbital 2 minutes before that. So it is hard to know whether it's both. Again, this was my protest, I suppose. The two things were there.
It involves removal of the anesthetic cream off the face of the patient. As we know,
I just
covers
stripped by my opinions, 20 thing, again, that's that. This was one of the first cases that we had from Australia where the supraorbital method worked. They had a patient going blind, and they just injected into the area. They didn't even do the foramen, and Michael Clegg and Greg Goodman, they restored that patient's sight. So this is just the area that they had gone into. And then Jean wrote a new paper just before IMCAS this year and said, I hold my hands up, use the supraorbital, don't use retrobulbar. So this was a lot of the papers coming in from China, like saying, there's no evidence that this works. Now, this brings us up to more modern times, and this is one case that I had from Sweden. I'm under legal obligation not to mention it, so I'll not go into it too much, but it's just interesting from the point of view that this patient had already gone blind, and we were considering using stem cells to restore her sight. And believe it or not, the embolus was in the cavernous sinus, and we know cavernous sinus causes blindness in children. Any of the thrombus or embolus is there, and they hadn't one directly in the central retinal artery, but the cavernous sinus is enough to cause somebody to go blind. Now, I'll take her off because she shouldn't be there. We had a case in Miami where a doctor using stem cells had reversed this patient's sight. And I looked at the case, and she had multiple sclerosis. So to me, I thought that was nonsense. People with multiple sclerosis will lose their sight and it'll come back again. It has nothing really to do with embolus or anything like that. Set up the situation in Sweden. This doctor here, Alex Skupin, and Alex Skupin used stem cells to restore her sight. And we had set up in Miami. But then they didn't want to do it there, so we were moving it to the Dominican Republic to do it. And believe it or not, something else happened in the Caroline Institute at the same time. I don't know whether you've seen that film on Netflix recently involving Paolo Macchini. Did you see that? He's an Italian doctor who was using stem cells to make patients live after tracheal operations. If you haven't seen the film on Netflix, do. It's incredible. It came out last year. And Paolo, we had invited to the Royal Society of Medicine, but believe it or not, he'd faked his results. 3 of his patients had died, so the Caroline Institute pulled out of doing the treatment. And this is our communication back and forward, so I'll not leave that up. So where do we go from there? The next thing, I suppose, that happened, and I'll just spin through this. Oops, I thought we were removing some of this. I was just making up this lecture earlier, and obviously some of it we need to remove. So then we had this case in Argentina, and the patient, again, had already gone blind, and I had given one of my books on complications to Fernando Silkovic, and this patient here had used my method, supraorbital. On day 7, she was beginning to restore her sight. On day 14, her vision was up to 20/25, almost 100%, and that was just the book that sort of They had used, if you haven't got this book yet, get it. They're translating it into Russian and Chinese. Now, this leads us on to a totally different way of doing this. That's where we were, but then this paper came out here from a friend of ours, Hung Nguyen, from Ho Chi Minh City in Vietnam, and they'd set up an interarterial thrombotic unit because they were getting so many cases of blindness, particularly from people doing noses. In Korea, in China, in Vietnam, unfortunately, everybody's doing noses. Beauticians are doing them. There's not just doctors, nurses are doing them. And they were having daily cases of blindness almost set into them. So this is Ha Hung's hospital in Ho Chi Minh City. And these were some of his patients. So he'd come up with a new method of going in through the femoral artery, threading it all the way back up to the ophthalmic artery with a sort of diagnostic unit that had multiple specialities on it, straight up to the point of the central retinal artery and using the Hyaluronidase there.
So what we can do? So we propose now the multidisciplinary emergency treatment with the plastic surgeon is the coordinate. So when the patient comes to emergency, we do the medicine in treatment like eye massage, diuretic, nitrodac, antibiotic, corticoids, and the plastic surgeon come for injection for subcutaneous or periauricular injection. And the eye doctor come for retrobulbar injection.
So this is what he was doing, and they took 10 patients and they restored the sight of 8 of them. One of the problems they found was the patients, like they were coming to us, were very late. They were coming like a week later, 2 or 3 days later, and already the eyeball had shrunk. And as a consequence, even if they restored the vision, they also then had to
Dr.
get...
Treacy, time is out. You can go on a few minutes more.
Will I finish? Okay, thank you. So these are some of
Recovery.
Ha Hung's cases.
The classic treatment, like medicine, the hyaluronidase, the subcutaneous or retrobulbar alone.
Okay, I've been through it. So these were some of the first cases that he had done. And then I invited him to Paris to the IMCAS session. And he showed us some of his work there. And you can see, for instance, the pinch of the central retinal artery and how it clears in the second picture. And that's us in Paris. And that was just what you should do. Would I have time to show this? Bedside management? Yes. So stop injecting, obviously, is the first thing. Don't forget, you also will affect the brain. 34% of visual impairment to fillers also affect the brain. They get a small stroke. So if we're going to employ sending these people to hospitals, maybe we should send them to stroke units. Involve an ophthalmic surgeon, examine the eye. So you need to check the eye, whether they can see on the other side as well. That's really important to document that because that's what the ophthalmic surgeon works from. And of course, you have to have Hyaluronidase in your fridge. There's no point in not. You see, that's our fridge in Dublin, and you can see that it's well stocked with Hyaluronidase. Use the supraorbital, supratrochlear. Thank you. That's enough.
Thank you so much for your great presentations. Süremiz bitti ama belki bir soru varsa alabiliriz. Buyurun.
Dr. Treacy, thank you for speech. I have 2 questions for you, clear questions. Is there any interaction between hyaluronidase and the other matrix proteins, except hyaluronic acid?
There's supposed to be, but believe it or not, the feeling is that most of the accidental damage that hyaluronidase does repairs itself within 120 hours. So they feel that in a few days it has restored itself. Now I know that when you go on the internet and you see these people who say, oh look, my face is destroyed with hyaluronidase and that, I've done maybe at this hundreds, if not 1,000 cases, and I've never really witnessed any problems. Now, you'll see on the internet as well where I have cautioned some doctors that they're using too much. Not mention a famous friend of mine in England, or sort of different opinions are up there, but he was advocating people use up to 8 vials, which is like maybe 100,000 units until you get the capillary refill time back to normal. Okay, you got a patient, they've got a vascular occlusion. Capillary refill time is less than 7 seconds, let's say. You want to get it down to 2 seconds. It doesn't have to happen in front of your eyes, as a lot of people think. You say to the patient, listen, we're on a journey together. This is going to take 2 weeks until you're fine. Let me get you out of trouble. I'll give you 1,500 units today, maybe later on another 1,500. I'll do that tomorrow and the next day. I may employ hyperbaric oxygen chambers as well. I'll give you some Cialis. It works as an oral nitrate for 2 days, maybe 3 days. It works at nighttime. I don't like using topical because it can cause syncope, number one, and you're not there in the middle of the night to put it on the patient's face. So I've never really used topical in a long, long time. I just use oral, and there's no point in using Viagra because Viagra only lasts for a couple of hours, whereas Cialis, tadalafil, lasts for a few days. So you've got to have the patient in confidence, and you don't want them running off to the hospital because the chances are that you know an awful lot more about how to treat them than the doctors in the hospital do. Now, if they have to go to the hospital, I have no problem. I'm not saying you shouldn't, but the thing is that if you lose the patient's trust, in other words, you're testing their face and it's still going from 7 seconds to 5 seconds, that's fine. It'll go down to 2. It doesn't have to happen in the first hour, or you know. And I think that's a mistake that a lot of doctors make, that they think, oh, I can't let you out until the capillary refill time comes back to 2 seconds.
So we shouldn't be afraid of injection then?
Nope, absolutely not.
Okay, second question is that what is your common approach to acute embolism? I mean, the dose regimens and injections.
No, somebody has cut you off. I see.
Daha sonra arada sorarız.
Soruları kahve molasında devam edelim. Uydu sempozyumuyla devam edeceğiz. 11. oturumumuzu kapatıyoruz.